Kameshwari from US going to take on the heart of preventive cardiology. Dr. Ashwin from Sweden. He will be focusing on the LV strain imaging in different cardiac situations. And third speaker is Reni from the USA is going to speak on the artificial intelligence, the role of artificial intelligence in echocardiography. So first I will request Dr. Kameshwari, please.
Namaste, everybody. It's a pleasure to be in the midst of all the greats. I certainly appreciate this opportunity to talk to everybody. I do know a lot of familiar faces. So my topic is going to be a little different than the previous speakers, and we're going to focus a little bit on what POCUS is and talk a little bit about POCUS guided care, because this certainly can be used in prevention at every level where we see the patients. I have no disclosures pertaining to these slides. And just a few learning objectives. What exactly is POCUS and how do we use it for cardiovascular applications? And as part of that, what exactly is lung ultrasound? And are there anything exciting on the horizon? So point of care ultrasound or a POCUS exam is an exam that can be performed at the patient's bedside. It can be used in acute clinical situations, and it can provide us with qualitative assessment very, very quickly and very rapidly. So you can triage and you can perform your assessment. The advantages are that it is extremely fast, you get immediate results, and the results are in your hand. The power is in your hand. It is completely non-invasive. It is dynamic. It allows for serial monitoring as well. So if you have a heart failure patient, you can go back and evaluate the IVC when you're treating them to make sure the volume status can be addressed. And disadvantages, it's highly user dependent. So in people who are novices at scanning, they may not be able to get adequate pictures, but that is going to change in the era of AI. We have tools that are actually going to help us, help even a novice user put the probe exactly where they need to and be able to get really good images. And it does not, at this point, provide complete quantitative assessment, but it is coming and it is in the pipeline. And I've seen some of these at the latest scientific sessions earlier this year, earlier this month at American Society of Echo, where you may be able to get a lot more quantitative assessment than what we were able to get previously. And for cardiologists, especially, volume status is very well defined. You can look for cardiac tamponade. You can look at LV and RV failure, which is a lot of our patients who are now getting admitted to the hospital. In the setting of pulmonary embolism, you can look for RV strain, because that is going to help you figure out whether these people need to get advanced therapies, either such as lytics or even be taken to the lab, and severe valvulopathies. So there are intrinsic differences. In our clinic these days, we encourage our cardiology fellows to put the stethoscope aside, not to completely forget it, but to put it aside, and we have POCUS devices. They can actually use the POCUS to look at the LV and RV function right away in the patients, look at the valves, and it is taking up ultrasound assisted physical exam. And that is something that really opens their eyes to anatomy as well as physiology, which is what we need to know when we treat our patients. The other thing is procedural. So you can use cardiac POCUS to answer basic clinical questions. So you have a question about volume status, you put your probe and boom, you get the answer. You can actually figure out how many B lines a patient has and how the IVC is, whether it is plethoric or not. So you can actually figure out the therapies you're going to be giving. And in the consultative cardiology, obviously, we do use a lot of traditional card-based echocardiography. So these are some of the probes that are there in the market that I have put in. I have used GE Vscan Air, Philips Lumify, and Butterfly. And I can say all the three that I have used have been phenomenal. They're very easy to hold, very easy to scan. So now that we talked about POCUS applications just a bit, we can look at cardiac, lung, musculoskeletal, urinary when you're looking for kidney stones, as well as the bladder volumes. You can look at musculoskeletal to look for tears. So there is quite a bit. But first of all, let us look at the POCUS applications in a case. A 73-year-old woman presented with a STEMI. She underwent a successful prox to mid LAD PCI with a DES approximately a few weeks ago. So transthoracic echo following the PCI demonstrated normal LV size and function, no regional wall motion abnormalities. And I am sorry that this decided not to move. So she comes in to the emergency room while I was on consult service with 8 to 10 out of 10 chest pain, crushing chest pain. And she had a little bit of interruption at an outside hospital where she was admitted for COVID. Um, and so her DAPT was interrupted. And she is here with crushing chest pain. ECG demonstrated no abnormalities. And you can see that the bedside POCUS images, which I have up there, are showing an apical wall motion abnormality. And cardiac cath lab was immediately activated. And because we had a huge concern for instant thrombosis, and there was a huge thrombus burden, she actually underwent mechanical thrombectomy and did redo stenting. And literally from when she hit the ED to when she got the care was just within 1 hour. It took a little bit of convincing the interventional cardiology team that it truly, we have a very high degree of suspicion. So some of the unique features of these probes, they have silicon chip array instead of the piezoelectric. So not that we should be dropping any probes, but even if you drop them, you're not going to be damaging the probe much. The image quality is reasonably good, and especially if you know how to image. Harmonic imaging is a feature, so you get really good endocardial border definition, as I have shown on the previous image. There is wireless and Bluetooth technology, so I actually can plug these devices into my phone, and I can look at the images as I'm doing them. So this is really good. Not only that, I can store these in the cloud and pull these images down as we need to review down the road. It has a low initial cost, low maintenance, and I think it may be a little bit more expensive in India, but I'm sure some of these, because of some of the restraints by the governmental regulations, are not really widely available here. So we talked a little bit about cardiac POCUS, and there are many things you can look at when we are doing it. LV size, RV size, you can look at stroke volume, you can look at cardiac output, PA systolic pressure, pericardial fluid. You can look at pulmonary edema, which as a cardiologist I'm most interested in, and also look at IVC collapsibility. So I will move on to some cases, and these are some of the regions when you do lung ultrasound that you should put your probe to be able to get images. And I'm going to be talking to you about what a back wing sign is. And here you see two rib shadows coming from the left and right. And then you see the lung tissue in the middle, and you see the A lines. The A lines are nothing but reverberation artifacts coming off the pleura. So having an A line just tells you you're in the right spot. So now let's move on to see what lung sliding is. This is actually pleura that is moving against the two surfaces. And it looks as though there are tiny little line of ants that are moving. So if you see that, once again, a good sign. And then remember, all these A lines are nothing but reverberation artifacts. So when you do lung ultrasound, all we are doing is looking at artifacts. which is something you don't want to see in traditional echo. And these B lines that you've been hearing me speak about are these ray-like, hyperechoic, vertical artifacts that are coming down. And those actually are signs of pulmonary edema. So just remember that these B lines are more sensitive and more specific than elevated pro-BNP, which is what we rely upon when we get a patient admitted. And they are much better than your physical exam and also much better than chest X-ray, where the sensitivity is only between 50 to 60%. So now let's meet a patient. This is a 73-year-old woman who presented with chest pain, shortness of breath, lower extremity edema. Her past medical history is significant for hypertension, hyperlipidemia, diabetes, and CVA. She was admitted with hypertensive emergency, underwent an urgent left heart cath with EKG abnormalities, which revealed a 3-vessel CVD. No PCI was performed, and the patient was waiting to discuss CT surgery options for a 3 to 4 vessel bypass. So she's currently in acute decompensated heart failure. She's got pretty significant LVH, as you can see on these images. And when we look back, she had LVH even on her previous echoes. And there was left atrial enlargement, there is pericardial effusion. It could also be consistent with hypertensive emergency that she has come in. We debated a little bit about amyloid. LV strain was not completely consistent with this. So obviously, the plan was to embark on amyloid workup and to obtain a cardiac MR. But you really need to ask yourself, what exactly is the etiology? Why does she have all of this? So I want to bring your attention to the cardiac MR, and you see this little intimal flap in the aorta that tells you, that makes you suspicious that there may be something more than what exactly meets the eye. And you're like, oh my God, is there a dissection flap? I'm sorry, the CT is not loading. It is a beautiful study, but once again demonstrated a type A dissection that was extending on to the descending aorta. And here you can actually see a formal echo, once again showing the LVH, so long-standing hypertension, with a type A dissection that extended into descending aorta, so type B as well. She underwent a successful emergent surgery, underwent repair of type A aortic dissection, including hemi-arch reconstruction. She underwent CABG and multi-layered sternal wound closure, which was very complex. And post-op day 4, echoes demonstrated normal LV function, mildly reduced RV systolic function, which is not uncommon for us to see in the post-operative setting. And luckily, no pericardial effusion. So around postoperative days 6 to 9, she wasn't thriving. She was reintubated. A bronchoscopy was performed at the bedside, group A strep. She was on antibiotics. She was hypotensive on postoperative day 9. A bedside POCUS was performed. And here it is. This was in the CTICU. OR was activated for emergent mediastinal washout. You can see that the RV was really compressed. And here is the RA also that is very, very much compressed. And she was having a limited tamponade physiology. And you can see that the IVC is plethoric. She underwent a mediastinal washout. 500 ml of clot was removed. There was serosanguinous pericardial effusion. She was discharged on postoperative day 30 to a long-term care facility. She needed a PEG. She had a trach. But overall, the whole point of doing a POCUS echo is it should be a goal-directed echo. Learn the basic views. These are very easy to learn. It takes us about an hour to teach people, and we do about 3 sessions and certify them. You need to understand what is normal. So then you can understand what exactly is abnormal. Segmental scanning is fine. Not everybody needs to get every segment in the same view. And POCUS is a very helpful tool for patient care. We actually published a paper recently in heart failure patients who were admitted to the hospitalist service, and showed that utility of POCUS actually is associated with significant cost savings. And this was just recently published in JAMA. And it is, remember, it's the cornerstone of bedside diagnostic assessment, and we should take responsibility in shaping the future learners. It is quite easy, has excellent diagnostic and prognostic value, and I thank you very much for giving me this opportunity to speak to all of you about this.
Thank you. We hear about the role of echocardiography, not only for the cardiac patient, but also rule out significant lung pathology. So we are moving to the second talk by Dr. Ashwini, who is going to speak on a very important topic on LV imaging.
Thank you for the invitation to give this talk. I will be giving a short talk on a relatively new application called strain imaging and how it can contribute to the area of preventive cardiology. I have no disclosures, but I would like to begin by drawing your attention to the global impact of heart failure. We know that heart failure affects more than 64 million people worldwide. 1 in 5 people are likely to develop heart failure during their lifetime. It is the #1 cause of hospitalization, and more than half of the patients that are hospitalized would need to be rehospitalized after 6 months. So needless to say, it has significant social and economic impact. It's also a fairly silent disorder. So it begins in a very benign fashion with certain risk factors such as hypertension and diabetes, and gradually progresses to higher stages of severity. And symptoms such as shortness of breath and fatigue, they present generally late in the presentation of the disease. Now, if you were to pick up the report of any patient with heart failure, you would typically see the mention of the ejection fraction. And this is a volumetric measure of the pump performance of the heart. It is the cornerstone of heart failure imaging. It's simple to perform, it's widely performed, and it is a part of the diagnostic evaluation of heart failure patients, but it has significant limitations. And one of them is it's a fairly late marker of cardiac dysfunction, and it has limited value in subclinical dysfunction. In the context of preventive cardiology, early detection would lead to early treatment. So I thought I'd bring up this image of a cold winter morning in Sweden and ask the question, what if we could detect heart failure before the ejection fraction fails? Strain imaging is a little like detecting the cracks before the ice breaks, and it can save a fairly large number of lives. Is that my timer? I think that was the previous speaker. So anyway, to drive this point home, I thought I'd present very quickly a patient who is undergoing a cardiac evaluation for cancer treatment. And before cancer therapy, this patient comes in and receives an ejection fraction, which is fairly normal. The strain, as represented in a bullseye map, also seems to be in the normal range. 6 months into therapy, as you can see on this image, the EF is still fairly normal. But what happens to strain, which is abbreviated as GLS, global longitudinal strain? There's a significant drop in strain. In other words, cardiotoxicity is caught by strain before the drop in EF, which we tend to see after 12 months. So I just wanted to drive home the point that strain changes before EF. What is strain? If you were to have a 10 millimeter spring and you stretch it to 12 millimeters, you would then say that you have like a 20% strain, and you calculate that by the change in deformation with relation to the initial length. Now, in the heart, if I were to try and simplify cardiac fiber deformation, you've got a large number of fibers. They work in different ways. In this image, you can see how the longitudinal shortening of the heart as the AV plane goes up towards the apex can be seen pretty much as you would use a French press in a coffee machine. In the short axis, the muscle of the heart thickens in systole. And again, simple analogy. And if you were to image the apex of the heart, you would find that there is a twist of the heart. So you've got slightly different ways in which the muscles of the heart work together to create longitudinal, radial, and circumferential strain. In the clinical scenarios, we typically just use longitudinal strain because it is the most robust of the three. Again, if you were to stretch the heart out, it's got a number of different fibers. What I would like to just emphasize is the image in the middle, which seems to say that the subepicardial fibers are oblique and they lead to lengthening and shortening, and the image on the right-hand side, which talks about the fibers which are closest to the blood pool. And that is why longitudinal strain captures early damage. The subendocardial longitudinal fibers are the most sensitive to early damage. How do we use imaging to capture this? Well, you can do it on echo, you can do it on MRI. Echo, of course, is widely available and fairly accessible. So you can use it using a technique called speckle tracking. Again, to give a very simple example, it's like tracking a face on Facebook. You look at the speckles that are created because of the interaction between ultrasound and the tissue, and you track these speckles, which are in little kernels, over time. There are a large number of clinical applications of strain imaging. I'll go through them very quickly. We've already talked of how strain imaging can be used in the setting of cardiac oncology. In this image, you see a large number of thickened hearts. All these patients have some form of left ventricular hypertrophy, and strain can provide some pointers into the possible etiologies. It's not foolproof, but it provides some indication of different kinds of etiologies. And each one of these are very, very different diseases which need to be treated in very, very different ways. GLS is also very useful for prognostic information in the setting of heart failure, irrespective of EF. In the more recent past, we have a large number of patients who are being hospitalized with preserved ejection fraction. And even in this setting, GLS would have prognostic value. In the setting of ischemic heart disease, if in this case you had a patient with atypical symptoms, no chest pain, no signs of ischemia on EKG, a suspicion of an inferior wall motion abnormality on the echo, but it wasn't sure. Whereas what strain did is it actually picked up the regional shortening and the post-systolic shortening of the regional inferior wall segment. And eventually on the cardiac angiography, this was seen to be a subtotal stenosis of the RCA. Intervention in valvular heart disease, particularly in the setting of aortic stenosis, is not performed unless the patient is symptomatic. In more recent times, there's been a lot of interest in asymptomatic aortic stenosis. And here also, we do find that strain has both diagnostic and prognostic value. The strain is not just about the left ventricle. This is some data from my group in Sweden, where we had assessed strain of the left atrium. And what we found in this interesting study was that the left atrial strain was it was a very sensitive marker to be able to discover early diastolic dysfunction changes. It was also very heartening to know that in the recent diastolic guidelines, which were just introduced a few months ago, they have introduced left atrial strain as an addition to the conventional guidelines. So my take home from this short presentation is that GLS is a sensitive marker that detects subclinical dysfunction. It enables timely diagnosis, risk stratification, and prediction of outcome across diverse cardiac pathologies. In the setting of preventive cardiology, early detection would translate into early intervention and possibly better outcomes. And so with that, I'd like to leave the stage on to Renee, who is going to sort of take us to the future with a little talk of AI in the setting of echocardiography. Thank you very much.
Thank you, Dr. Ashwani. So due to short of time, we are moving to the next speaker, Dr. Reni, who is going to speak on a very important upcoming topic on AI-powered echocardiography. Please.
Years now at the University of Rochester in New York. I'm here to talk about the artificial intelligence in echo nowadays. Let's see. So, what is artificial intelligence? We all talk about AI all the time, but what is it? It's basically a computer program that can perform human tasks and mimic our thinking process. The most common uses in AI and echo currently are like what Dr. Ashwin was just talking about, is the strain analysis or the speckle tracking. Also, we use the automatic LVEF calculations. We can also do 3D and 4D imaging, and also just regular 2D measurements automatically. Our current limitations in AI are the limited knowledge because it's so new, not so many people know about what we're talking about. Also, not having the proper equipment, whether it be the software or the physical equipment, different manufacturers, different settings, different users. And also, our patient population can sometimes not have good image quality in acoustic windows. So that can definitely cause not so good AI. So how can AI, that looks a little weird. How can AI benefit us as sonographers and providers? The critical care specialists have limited time to diagnose their patients in an emergency setting. So using like the POCUS ultrasound can help us to diagnose any immediate dangers to the patients. It can also decrease our human errors in producing automated images on a consistent basis. So as some of you may have seen me yesterday in the medical camp, I was using this V-scan probe. This did have AI capability, and you can hook it up to your phone, a tablet, it's a Bluetooth. It also had a cardiac and a vascular probe. With the AI component, it basically tells you if you've got a good picture or not, and if you do, it will take it automatically. And then where you can move your probe with angle, direction, or space on the body to make the picture optimize. And this will help any like newer sonographers or even providers or fellows who are not used to scanning. They can help get their pictures better. And that's all I have. Very quick. Thank you.
Thank you. So, any questions from the audience for any comments, any opinion?
All the three presentations were excellent, lucid presentations. But I just one or two questions. In the LS strain and LV strain, you mentioned about the diagnostic and prognostic implications. Are there any therapeutic implications around of LS strain with medication or with intervention? Does the strain reduce or the strain is not affected? This is strain, LS strain or LV strain. You mentioned about diagnostic and prognostic implications, but what are the therapeutic implications? Therapeutic. Okay.
So if I got your question, you're asking about the therapeutic implications of left ventricular strain
As well as LS strain.
and left atrial strain. That's a fantastic question. So, well, for one, I think left ventricular strain has a strong therapeutic implication in the setting of cardiac oncology, of course, in the setting of patients who are having anthracyclines, and to be able to determine cardiotoxicity before the EF drops. LV strain has been, we can talk of LV strain in the, let's see, I'm wondering if Dr. Kamu, would you like to add some?
Sure. Ashwin, just to agree with what you've said, there is significant amount of data about the utility of LV global longitudinal strain, more so in cardio-oncology situations. Once you actually have patients who have been treated with either beta blockers and or calcium channel blockers, and or ACE inhibitors or ARBs, you can actually show improvement in GLS. And I think some of the earliest area where we see a lot of this is with the HER2 inhibitor therapies. Much more so than anthracycline therapy, there is a little bit of improvement, but it is much more profoundly noted in the HER2 treated patients. We also see a significant amount of improvement in patients with both HFrEF, where it is most profound, as well as HFpAF. More recently, when you have somebody on GDMT, you can improve the strain. In fact, not just LV-GLS, but also LA reservoir strain that significantly improves. And we do, obviously, all of us in cardiology community do get worried if the LA-GLS reservoir strain especially goes down below negative 18%. So that's one of the things that we target as well. But an excellent question with therapeutic implications.
Just one smaller question. Number of times it happens that the electrophysiologist do radio frequency ablation for atrial fibrillation, but the LA fibrillation, this atrial fibrillation is resistant or persistent, refractory, not responding to radio frequency ablation. Is there any relationship with the reduction of the LA strain?
So in the setting of AFib, looking at LA strain can be a bit of a challenge. And also in the setting of both paroxysmal as well as permanent AFib, you do notice that the LA strain does go down. But therapeutic implications post, I am not exactly certain post RF ablation or post PFA. I'm not certain, even with electrical normalization, whether there is true mechanical normalization. That is an area that still needs to be studied, I think. But again, excellent question. And I think we already know that the strain in AFib is going to be abnormal, the LA strain, but therapeutic implications, I'm not 100% certain in that area.
Okay, if there is no more questions, we end this session on echocardiography. Kindly give a big applause to all the three speakers. Thank you very much.
We extend our sincere gratitude to all the doctors and cardiac sonographer for an excellent